Good afternoon, everyone. Good afternoon, everyone. Thank you for joining this Gecko session that's hosted by the Gastro Foundation in association with Project Echo at the University of New Mexico. These sessions are held weekly on a Wednesday. Today, we are going to be talking about the endoscopic management of bile duct injuries and specifically Strasbourg E bile duct injuries. So I'm going to be speaking, and so is Sam Wanjara, who is one of our fellows in Cape Town. Mohammed here was also supposed to speak, but he's still busy in theatre, so I'm going to speak on his behalf. All right, so we're going to start off with Sam. Sam?
Thank you, Professor Bernon, and thank you to the Great Call Foundation for the opportunity to share a case that we managed at our unit for typical bile duct injury, Strasbourg E. Just going to share the case, and I'll just get started. And maybe along the way, I might ask part of the audience to suggest what they would do in certain situations. And I hope it will be helpful to how we address bile duct injuries and specifically the complex one like we'll share. So the case that we'll be sharing is for a 30-year-old female who was referred from a district hospital with jaundice and rising bilirubin levels of above 100 for and had a lab chole 8 days prior, and the lab chole was for symptomatic cholelithiasis. From the surgical notes, it was noted that it was a difficult cholecystectomy, and our patient had no comorbidities. On examination, when we saw her, she had a performance score of 0, and she was febrile and jaundiced. Her vital signs were normal, live for the tachycardia of about 101. She had right upper quadrant, not peritonitic, and her white cell count was 9, and HB hemoglobin levels of 17 with INR of 0.7 and raised transaminases. From the LFTs, the canalicular enzymes were notably elevated, and she had normal electrolytes and renal functions. So probably at this point, I would want to hear some opinions on how we could have addressed this or how you could address this if this was in your unit. And I'll open the floor for suggestions. And there's no wrong answer with this.
Anyone want to raise their hand?
You can shout the answer, raise your hand, or just type.
Mohammed?
or
Ahmed?
Yes, Prof. I would start with the abdominal ultrasound to see if there is any collection to, and then after that I want to do from the ultrasound, then I will see if there is evidence of collection. Rather, after stabilizing the patient, I will start IV antibiotic, resuscitate the patient, IV antibiotic, and then according to what is the finding. If there is collections, is it? I want to know: is it side duct injury? Is it complete transection, or is there is a ligation? I want to know what the type of the injury. So either I'm going to do CT scan or MRCP according to the findings of the ultrasound.
Thank you very much, Dr. Mohammed. And in our case, we went ahead and did the CT scan. The CT scan in this setting has two advantages. As you noted, to highlight if there are collections, And the other advantages, I think, will come across them as we proceed. I don't want to preempt that. So this CT scan for the patient, and sorry for the background noise. Dr. Mohammed, would you want to continue? But we can also get comments from the audience. But yes, Dr. Mohammed,
Yeah,
you're free to.
would you repeat again the CT scan? Sorry.
Sure. So, uh, did you?
It's jumping.
Okay, I'll just slow it down. Probably pause. I can pause it at that point.
Okay. I can see, yes. Look like prominent dilated bile ducts with clear evidence of pneumobilia because I couldn't see it. The CT scan is not clear. Look like there is pneumobilia also, if I'm right. I can
All
see
right.
up to the confidence.
Yeah, thank you. Apologies for the poor quality of the scan, but you are right. So there is dilated intrahepatic ducts, and the proximal common hepatic can also be seen to be dilated.
Yes.
That's one of the things that you'd be looking at from the CT scan. You'd want to know in the setting of such presentation. The other thing to note is that there were very minimal collections, if any. So any other thing you'd want to know from the CT scan, Dr. Mohammed? And sorry for picking on you. We'll just continue. There is no
Yeah,
wrong answer.
that's fine. I want to also, beside outlining so I outlined the bile duct injury, and I want to see if there is any associated vascular injury with that, if it's possible.
Perfect. So we agree, and that's what we did. There was a proximal Strasbourg injury, as you can see from the coronal that I shared in the last previous slide. There's a clip high up in the proximal ducts. There's no arterial injury. The liver is homogeneous in this CT scan, and there's no overt collections. So after this, I think I went to the next slide, and I might have given Mohammed the answer. But yes, you had mentioned it. After this is to classify the injury and also to know the level. And for this, one would typically perform or ask for an MRCP, which gives details of the level of injury and also severity, so that you're able to determine the management options. In our case, the patient had jaundice, and there was a need for us to decompress. As you've seen on the CT scan, the ducts are quite dilated. In this case, we went for percutaneous transhepatic cholangiogram, which is shown here with a clip across the, let me just give a pointer. Yes, a clip right across the proximal common hepatic ducts and the dilated system. At this point, what would be your options, Dr. Mohammed? Oh,
Yes.
the floor is open. We can get comments from anyone in the audience. Just feel free to shout or type your response on the chat. And yes, Dr. Mohammed, you can proceed if it's okay with you.
From what I'm seeing here, Dr. Samuel, I guess I can see the confluence. So what I'm seeing here, because I can see the posterior, the right posterior, the right anterior, and the left. So I guess the confluence seems it's like intact. Uh, I believe this could be type E uh,
Yeah,
injury.
you're very correct. So that's what we see here with the clip
Yes.
right across the proximal ducts. How do you proceed from here?
Uh, okay. So because as you mentioned, there is collection. So as I mentioned earlier, I will continue the supportive management of the patient. I will address the collections. I want to drain the collections. If it's possible, if the collection is significant, I can even go by laparoscopy and do washout and put a drain. But also, you mentioned there is a clip towards a branch of the right hepatic duct. Am I right? That's what you said.
Yes, as you can see where the laser pointer is, that's a
Yes.
clip that was put at the point at the time of surgery, and
So yeah.
so we have an iatrogenic Strasbourg E. So
So
the priorities, yes, Dr. Mohammed.
yeah. So I'm saying with associated arterial injury or vascular injury, the patient, if the patient is stabilized, I guess I should wait to settle down and to see the effect of this arterial injury on the ducts. Okay, so I will wait for at least 4 weeks if the patient, if everything is fine and the infection have been addressed and the collection have been addressed successfully. Then I will reassess the biliary system again to see if there is any effect of this arterial injury in terms of atrophy or other things. Then accordingly, I will see the possible what do you call it, option of management. Uh,
Yeah, you're right. And in this case, the biliary drainage and decompression was done via percutaneous transhepatic biliary drain, as you can see here, done at the same sitting with this PTC. And after achieving the drainage, we went ahead and did an ERCP. And at this point, after the PTC, after the PTBD, you can see the bilirubins decreased, came down significantly, as well as the canalicular enzymes. And after that, we went to do an ERCP, and this case was elected for endoscopic management. So at ERCP, as the panel on your left shows, you can see that the guide wire is up, the distal bile duct has been cannulated. The guide wire is up in the duct, but has detoured into a collection where contrast is pulling. And as well as you can also notice that there is a gap between where we had previously seen the clips from where the contrast leakage is. So at this ERCP, we put a distal fully covered metallic stent, biliary stent, as shown on the panel on the right. And at a later date, the patient went back to the IR suit. The Achilles heel, as highlighted on this slide of endoscopic management, as we'll demonstrate, relies on successful cannulation of both the proximal and the distal duct, basically bridging the gap. So IR comes in handy. And as you can see, I'll just replay that. The patient is in IR suit, and you have access of the proximal through the previous PTC, and you can see guide wire coming all the way to where we had previously seen the clip. Subsequently, the radiologist tries to knock off the clip using the guide wire. Just going to show that. Yes, and once they can they knock off the clip, they as well try to cannulate the stent that we had left at ERCP, which is achieved here. As you can see, the clip has been knocked off. The guide wire from the PTC has been advanced into the distal metallic stent previously placed at ERCP, and you can see contrast flowing through the stent into the duodenum. Subsequently, a guide wire is passed to the duodenum through the PTC. And that, in our opinion, is the Achilles heel of of bridging the gap. And after that, the patient went on to have subsequent ERCPs. At the second ERCP, as shown here, now we are able to cannulate the distal bile duct. And remember those stent and access from the previous PTC, which had been internalized. So internalization of the PTC enables and secures the access. At the ERCP, we push two guide wires to both the left system and the right system. And the stent that had been placed at the first ERCP is retrieved and replaced with now a bridging stent into either of the systems. In this case, the stent was placed in the right system, a metallic stent in the right system, and as shown here, a plastic biliary stent in the left system. This is a cholangiogram done at the same sitting, and you can see there is no extravasation of contrast. The biliary system, the intrahepatic biliary tree is well opacified, and that is a technical success. So after that, the patient was discharged, and the gap, then the continuity of the biliary tree had been achieved, and was booked for a stent exchange at 3 months. And at 3 months, the stent was removed, and you can see here there's a balloon dilatation of now the fibrosing bile duct. And there's at 3 months, there's inflammatory tissue where the gap was, or where the defect was. And after dilatation of the system, now we see a fully covered metallic stent, this time placed in the left system, and a plastic stent in the right biliary system. And the patient was booked again for a stent exchange after 6 months. At 6 months, you see the stent was put on the contralateral system, and 2 plastic stents placed on the left. At 18 months, these are after a year or plus, we see here at ERCP, the patient had been booked for stent exchange, but at a cholangiogram, you can see, if you're able to locate my cursor, there's a balloon cholangiogram being performed. There's the balloon in the proximal ducts. And on this one is a balloon again in the distal duct. And the balloon sweep was achieved without resistance, and there was no extravasation of contrast. At this point, it was safe to leave the patient without a stent, but the patient has been enrolled for follow-up. So the technique is correctly termed as minding the gap, because as you can see, where the hybrid technique managed to bridge a rather complex bile duct injury. And in the literature, this technique has also been termed as the lasso technique, the percutaneous endoscopic rendezvous procedure, or the combined endoscopic and radiologic approach. At our institution, we prefer to call it mind the gap. And we have a number of patients that have been managed successfully with this technique. It's apt for patients with complex biliary injury, and especially the subset of patients who have lost a portion of the bile duct. And as we saw on the slide that I put up, the Achilles heel of the procedure is getting two separate access sites meet at a common point, and then capture of the a guide wire from one of the access sites and pulling it through the other end, and then bridging that with a stent. Follow-up is recommended to be done every 3 months, and the goal for the long-term management and eventual success is achieving continuity of the bile duct and patency of the bile duct. Pertinent question to this technique is when to remove the stent. As you've seen, for a patient we removed, for this particular patient, we're able to remove the stent at 18 months. Going back to Dr. Mohammed, when just a random guess, you might not have done this, or you might have had experience with this, but what would be your optimal time to remove the stent?
I guess this is could be different from patient to patient. From my perspective view,
You're very
it's
correct.
yeah,
You're very
according
correct.
yeah.
Yeah, the time to remove the stent is at the discretion of the surgeon or the team managing the patient. But as we saw, the end goal is getting continuity of the bile duct and having a patent duct. But the prerequisites to removing the stent is you have to make sure that there's complete continuity, no significant narrowing, in which case you will have to restent to avoid hold up. And also you need to ensure that there is no contrast medium being excreted or extravasating from the injury. Follow-up duration also ranges, and I think that's one of the things my colleague Prof. Bernon will highlight in his talk. And this is just a diagrammatic schema highlighting the minding the gap technique. So you see here we have a Strasbourg E injury, and the first access here has been achieved with endoscopically with the TRCP. You pass a basket This is the typical basket that we use for stone removal. And then you pass another guide wire from percutaneous transhepatic route, and you aim to capture that guide wire with the endoscopic balloon. And then you retrieve that and you pull the guide wire across. And at this point, you do the usual rendezvous procedure, and you follow up with stent placement and stent exchange. So this procedure, the minding the gap technique, as we mentioned at the start, is useful for managing complex bile duct injuries and can be utilized in case of trauma or iatrogenic injuries like we saw for our patient, but has also been used for bile leaks after hepatectomy and after liver transplant. So that's what I had for you, and I'll invite questions and comments, and also comments from Prof. Bernon.
Thanks very much, Sam. So are there any questions or comments? Obviously, this is not the standard way that these bile duct injuries are usually managed, but as Sam said, we have now managed a few patients like that. Mohammed?
Thank you, Prof, and thank you, Sam, for the presentation. I'm just wondering if there is any limit for uh, the maximum length of the gap that we can try such procedure. Is it and in terms of presence of such vascular injury like this case, should we wait or do it like and the first early or delayed or which the timing for this minding the gap
Sam, do you
intervention?
want to answer that?
Yeah, sure. Thank you for those two key questions, Mohammed. I think they highlight the utility of this procedure. With minding the gap technique, it can be utilized to address these complex injuries quite early. And as you can see for this patient, it was day 8, day 10. So yeah, it can be used for early interventions. And we know that the bile duct is basically muscular, not muscular, but just a conduit. And that means that if you're able to bridge whatever length you've lost, uh, the tenet here is being able to bridge the gap. If you're able to bridge the gap and stent across it, then yeah, that puts the patient at a better position for continuity, achieving continuity after fibrosis around the stent. And that's also a key tenet for this procedure. So the length of the gap basically doesn't exclude patients.
Thanks, Sam. If there are no other questions, then I'm going to move on. I'm just going to share my screen. Just hold on. Let's see how I can do that. Share. Are you seeing that?
Yes, we can.
Okay, great. So I just want to follow on with from Sam's talk, and this idea to do this came from Professor Jonas, and I'm going to show the first case that gave us the idea, and we've now done it in probably about 10 patients who've had some sort of bile duct injury. And I just want to highlight the different types of bile duct injuries. The commonly used classification is the Strasbourg classification. So Strasbourg A injuries where there's a leak from the cystic duct, or Strasbourg D injuries. Let me just see if I can show you. Strasbourg D injuries. Sorry. Can you see my pointer?
Yes, we can.
Let me just use this one. Sorry. Yeah, that's better. So Strasbourg D injuries where there's a leak from the side, where there's an injury to the sidewall. There's no, I don't think there's much controversy about that. Those or endoscopic management is ideal for these. It's the Strasbourg E, this group, where there's a complete transection of the bile duct that this is new. And we know that but there's an endemic of bile duct injuries that started since laparoscopic cholecystectomies have done. Our units repaired more than 300. What often happens is these cases end up in court. Strasbourg also described the critical view of safety, which is demonstrated here in his paper. And we know there's three components to the critical view of safety. You have to clear the hepatocystic triangle. You have to dissect the lower third of the gallbladder off the liver, off the cystic plate, and there should be two and only two structures entering the gallbladder. And failure to achieve the critical view of safety means that you are not able to proceed with clipping the cystic duct. Fortunately, people don't stick to that rule, and we end up with these situations where the common bile duct is excised with the gallbladder, and these injuries can be devastating. We've had patients die from them. We've had patients who needed to be transplanted, and they often spend a long time in the hospital. The blood supply to the bile duct was described by Professor de Blanche in 1979. And basically what we know is that there's an artery that runs at the 3 and 9 o'clock position on the side of the bile duct, and those arteries are fed superiorly from mostly the right hepatic artery and inferiorly from the gastroduodenal artery. So the result of that is that the this area in the middle is a watershed area, the area where bile duct injury is likely to occur. And that's meant that our surgical technique is always to repair this has always been a hepatic jejunostomy right up at the biliary confluence. The other thing to take note of is how closely related the right hepatic artery is to the bile duct, and that is often injured, as Mohammed pointed out, and Sam. And if you have an arterial injury associated with a bile duct injury, you worry about ischemia at the hepatic jejunostomy, and that's often a reason why we delay the repair. So those are particularly complex injuries to repair surgically. Also, sometimes these patients are really sick. They can't undergo surgery, or they're not really great surgical candidates in the first place. And that's when it becomes really attractive to try and deal with these things endoscopically. And in our experience, I think patients are less likely to sue the injuring doctor when these operations, when these things are managed endoscopically as opposed to with a big hepatic jejunostomy. So the first case was not actually a iatrogenic bile duct injury. There was a 40-year-old who was a security guard, and he was shot during a robbery, a thoracoabdominal gunshot wound. The entrance was in the left anterior axillary line, the sixth intercostal space, and the bullet traversed the midline, went through his left forearm. He was hemodynamically unstable, ended up with bilateral chest drains, which drained a significant amount. And he ended up having a laparotomy. There was bilateral diaphragmatic injuries. You can see the bullets, some of the bullets. And there was an extensive injury noted to the left lobe of the liver. The liver was packed. This was all done by the trauma surgeons, and we were not really involved in this initial management. The packs were removed on day one. There were no missed injuries in the abdomen. The diaphragmatic, well, the the chest was washed out, the diaphragmatic injuries were repaired, the stomach injury had been repaired, there was no bleeding, drains were left around the liver, and a nasojejunal tube was placed. So this just gives an idea that this CT scan was done later of the tract of the bile duct of the bullet through the liver, and you can see how it passes very close to the center of the liver, close to the porta, and so we started off. He got a collection, and he ended up having a perk drain. He then had a persistent bile leak. So on day 11, we did a ERCP, and we weren't expecting this, but there was basically no continuity of the bile duct. The bile duct had been completely transected by one of the bullets. You can see the cystic duct is still in place. So we now had this patient who'd had major trauma, who had a transected bile duct. We then got an MRI done. Didn't really add very much, but just to confirm that the bile duct was off, you can see this tract of the bullet going right through the middle of the liver. So you can see the perk drain. He then had, let's see if this plays. So he then had a PTC done on day 18. And at this PTC, if you look carefully here, you can see contrast entering into the portal system. Let's see if I can show it again. Sorry. Go back. So there's a portal, or a biliary portal fistula. So he wasn't bleeding into his bile duct at that stage, but we felt that we probably needed to try and get a stent into the bile duct somehow and seal that off. So this was a picture of the PTC and an ERCP being performed simultaneously. You can see the guide wire being passed up via the ERCP. So let's move on. And we managed to capture the PTC, and then we basically used that to bridge the gap. You can see a metal stent that was placed into the bile duct. So that was our first sort of mind the gap rendezvous procedure. So then on day 22, he developed bleeding, and he had basically a false aneurysm that we think was caused by one of the bullets from his hepatic artery that was now bleeding into the bile duct, and that was managed with a stent that was placed arterially. So in the end, he ended up with this stent, this biliary stent, an arterial stent, and a PTC, and that this happened. Now it's probably 6 or 7 years ago, and we've now removed all the stents, and he's still fine, and never required any surgery to repair his bile duct. So this was the first case that we did, and it was sort of through desperation and necessity, and the fact that we didn't want to operate on someone who had been unstable, who had a portal injury, a completely transected bile duct, and an injury to the hepatic artery. And I think just shows how much you can do with endoscopic and endovascular management. I think we would have killed this guy if we had tried to repair this surgically. So like I said, that gave us the idea. Then subsequently, when we've had some difficult Strasberg E bile duct injuries, to do it. So this was one of the first laparoscopic bile duct injuries that we had, that we did this on. And so you can see this was in 2017. The patient arrived a little bit septic, jaundiced. I'll see if I can show you the scan. So let me see if the scan will play. Sorry. Sorry, I'm just struggling with this. Sorry, I can't show the injury. Anyway, once again, there was a completely transected bile duct. This was what the MRCP showed. You can see that there was a surgical drain that was left. Um, ugh, sorry guys, I don't know why this is not playing. And once again, we did a PTC and a ERCP and managed to internalize the whole thing. So that was the second patient that we managed. And then the last case that I wanted to show you was a patient who had a liver transplant. Just really want to see if I can just get this working. So I think what we're trying to show here is that that he developed an hepatocellular carcinoma. It's a guy with cirrhosis, a small little hypervascular lesion that you can see over there. It was treated with microwave ablation. You can see it there. And then subsequently, he developed new liver lesions. So we now had a patient with multifocal HCC who fell into transplant criteria. And he ended up having a liver transplant, which was quite complicated. He had to go into bypass during the transplant. We had a problem with the hepatic artery, and that is often associated with biliary injuries. He had an hepatic artery thrombosis we fixed, which we managed to sort out. And he then, on day 51 after the transplant, started to become jaundiced. And basically, there'd been a complete breakdown of the bile duct anastomosis. It was a bile duct to bile duct anastomosis. He was at that stage quite sick, and so he ended up having a PTC. And we had at that time just managed the trauma patients, and that's what gave us the idea to do this bridging thing again. And you can see ERCP and PTC. You can see us there going with a basket from below. Sorry about the sound in the background. Turn that off. You can see, I don't know if you're going to be able to, yeah. So basically, we managed to grab the PTC and pull it down into the bile duct, and then that subsequently allowed us to place a stent, and that's how we managed this biliary injury, this breakdown of the bile duct. And his transplant was in 2017, and he survived until I think 2025, with occasionally needing ERCPs and stenting of the bile duct. But there you can see this was the 1 year result, and there were times where he didn't have stents in at all. You can see the pneumobilia. There's the stent. So we've used this now for trauma, for transplant, and for iatrogenic injuries. So that's basically what we wanted to discuss. I don't know if there's any questions or comments. Just to say that you can manage Strasbourg E injuries endoscopically, and often it's I think the preferred method if you've got a patient who's not a good surgical candidate. Any questions, comments? If not, we'll end the meeting. So I just want to say thanks, Sam, for your presentation, and thanks to the Gastro Foundation for allowing us to do these presentations, and thank you to the ECHO University of New Mexico team and the ECHO India team. Recordings of this will be available on the Gastro Foundation website, and next week's talk will be on patient blood management. Thank you, everyone.